Two of the codes are very much technological codes. The 99453 is a code that's reported once you've installed or given out and taught and trained that patient on how to use they say it's a medically cleared device, an FDA cleared device that's going to easily grab information from the patient without them manually entering it and easily synchronize that patient back to the office. So those are the criteria to be met for the 99453 for the RPM program to really kind of begin. That along with consent. So there has to be documented consent in the record that the patient understands that they're coming under an RPM type services, that the physician will be monitoring this with their clinical staff. Again, it's a good idea to put in there that they will not be monitoring it live. It's also a good idea to let the patient know that this is a normal covered service, but in doing so, it's only covered 80% by Medicare, and any sort of co-pays or co-insurance may be the patient's responsibility. It should be a good idea to document not only that they are going to be put under RPM and gave consent, but for what conditions. And ideally, it should be chronic conditions, though Medicare has loosened that up to acute conditions as well. But ideally, you're going to say, to help manage these conditions, whatever those conditions are, we're going to enroll them into RPM using what, we're going to be monitoring blood pressure, heart rate, respiratory rate, weight, whatever happens to be. So that's the 99453. It pays one time upon enrollment for about $20. If you discontinue the program and there's quite a gap between enrolling that patient again and they have to get the equipment back and send the equipment back out, it could be billed again. But typically it's just billed once. Multiple providers can be overlapping on RPM, and RPM can overlap with CCM as well within the same practice. Patients who then successfully get that data back or alerts back to the physician that should be collecting at least 16 out of 30 calendar days from that point qualify for the next technology part of the billing, which is the 99454. So if you do not get 16 days, you cannot bill this code. So for example, if you started someone on the first of the month, did a full month on them, and you got 16 out of the 30 days, at the next 31st day, you could start collecting that 16 days again as far as counting. And if the patient then discharges or goes in the hospital on the 12th and never comes back, you wouldn't have achieved the 16 days, so you cannot bill for the 99454 again. And just as a side note, which we'll talk about a little bit more in billing, the 453 could only be billed once a successful 454 has been built at least once. So 454 is done on every 30-day basis. It can be dropped once the 16 days occurs. You can do your billing, but really best practices it just says wait till the end of the 30 days to make it easier for the billing company to do this all in one swoop. The 99454 does pay back about $64 based on LCDs and local reimbursement. 99457 and 458 are the interaction codes. So Medicare has clarified for 2021 there needs to be some live interaction during those codes. It doesn't have to count for all the 20 minutes, but some of that time has to be a phone call, a video telehealth call, some live interaction to make these codes count. Prior to 2021, it wasn't clarified that it had to be live, so people were sending messages back and forth in an asynchronous manner. Even if they were at the platform answering it live, it wasn't considered live. So it needs to be a phone call or a video call to successfully bill for the 99457 or 458 interaction codes. And again, this interaction is expected to be done by a lower down clinical staff, part of the Incident 2, which is typically an MA. So they're going to be watching this data that comes in, responding to it, again, not live, maybe every other day or every 3 days or once a week. And when they document in the system, every 20 minutes of documentation, the first 20 minutes, once they get to minute 20, and they've had some sort of interaction that calendar month, this one's a calendar month, they could successfully bill for 457, which reimburses about $51. For the next additional 20 minutes, so now up to 40 minutes, not 38 or 37, but 40, 41, 42 plus, the physicians can then bill for 99458 in addition to the 99457, which adds on about another $41. Some months they may get the 458 in addition to the 457, some months just the 457. Best practices, which I'll teach in a little bit, really says you can go for the 458 just about on every month, assuming that the patient's enrolled early enough within the month to get those codes. So a patient, this one's calendar month again, a patient who comes in maybe on the 20th of the month is very unlikely to get the 458, but they're very likely to get the 457. This needs to be documented in the record, either in the RPM system that can be retrieved or in the EMR itself, but the task needs to be documented. So MA would log in and say, performed 10 minutes of chart review, saw data showing trends in elevated blood pressure, notified patient to come in for a new visit, and notified physician of elevated blood pressure trends, and we'll deal during next encounter. Something like that. It just talks about the fact that you reviewed the data, what did you see, and it could be gross. You don't have to talk about the actual numbers, but you just talk about trends or patients looking stable, no alerts, no trends in the wrong direction kind of thing. So if you look at this little grid here, starting up at the top, the initial setup of the equipment, day 1 of data transmission, let's just call that on the 15th of the month. You can't bill for that until you get to 16 more days at least of data transmitted, which is the earliest that would be, if it's a 31-day month, would be day 31 of that month would be the earliest you could bill for that. But just because you bill for it on the 16th day, if you got 16 days of concurrent transmissions, doesn't mean that you can start billing for the next batch of cycle then. You have to wait till the 30th day, and then afterwards you can start your 30-day cycle again. So you have 30 days to get 16 days of data transmission, and you don't need continuous data transmission. 1 data point a day is fine. So if they're giving you 1 data point every other day, if they even miss 1, you're going to miss it out for the month. So ideally, you're collecting this daily. Once you have your end of your 30 days, you can bill for the 99454 with a date of service of whatever that date is, and you want to point to the ICD codes of those chronic conditions you mentioned that you're going to be observing or treating. The 99453 gets billed once. It can only get billed once the first 54 gets billed, and that can have the date of service going back to when that was first installed. After that, your clinical staff takes over. They're looking at the documenting the minutes they've spent, and again, it does not mean minutes spent talking to the patient. Each time you open the chart and record and do anything, the Medicare understands that it takes some time. It takes some time to look within the RPM solution, take some time to review the data, compare it maybe to your EMR. So, it can build up pretty quick. Each time you open that chart, CMS estimates that it might be 8 to 10 minutes worth of work every time you open up a chart. So when they've spent this and looking at the alerts and they get 20 minutes, at the end of the calendar month, they could bill for that 5/7. And again, you wait to the end of the calendar month because you never know what's going to happen. You might get 20 extra minutes in the last night. So you do this billing at the end of the calendar month. The data service would be the end of the calendar month, and it's going to be pointing again to the ICD codes appropriate for this patient. And you always bill 457 on the 20 minutes, and if you get to 40 minutes, which is 20 additional minutes, you can then bill for the 458. There really is no need to bill much beyond that. You don't really want to see 60, 70, 80, 90 minutes spent on this patient when really the first 2 are the ones you get billed and reimbursed for. So 457, 458, roughly 40 minutes. If you look at it at about 10 minutes of chart review per week, that gets you your 40 minutes. So even if you're doing 5, 6, 7 minutes per week, but then responding to alerts and doing some phone calls, you can easily get to the 40 minutes. However, you should be aware that these data reviews and closing the care gaps are going to probably bring up the fact that this patient may need to be seen sooner than later before their original appointment. This might be done through telehealth, it might be done live. So some of this is going to spin off the need for more appointments as needed rather than appointments as scheduled. You continue this monthly. There's no reason to stop necessarily an RPM program. The intent is if you're enrolling people who are kind of that medically fragile state, it's a way to close those care gaps every month and not wait till they end up in the hospital before you find out about it. So you continue collecting this data, you continue collecting and documenting information on them, and you bill for this on a monthly basis. And again, usually most companies will do this all at the end of the month. They'll hit the whatever billing was appropriate for the 5/7 and 5/8, and some of them will bill just kind of whenever that 16 days hits or whenever that 30-day cycle hits based on when the patient started their plan.